So today, I'd like to discuss the internal structures of the brain and their role in the intra-axial tumor extension. So before starting, I want to share my work, the dissections, and those dissection can be found the Rotman collection free, and just it's enough to open create an account, and you can reach out all this the pictures for the residents like educational purpose. Sometimes the people ask me about, what kind of surgical instruments I used for the fiber dissection. You can see I was fortunate to have like this is University of Florida, Dr. Rotman's lab. I have a Rotman set here, also microsurgical instruments. And but nowadays, in Turkey also there are really great the skull-based labs and just the very nice the fine instruments that just can be reachable. Uh, let's start our issue. It's possible to subdivide the brain three parts, like cortex, outer layer, and the white matter, the fiber tracts inside, and we see the cerebral core or the basal ganglia area. And it's actually it's very similar architecture. The brain architecture is very similar to the fruit. Like the cortex is kind of peel, the fiber tracts is the white matter is kind of inside, and the central core, or in other words, the basal ganglia is like the seeds of the fruit. What we know about these structures, the cortex is uh, kind of we know that the cortex has a plasticity, which means in case of the tumor or after surgical manipulation, it heals itself and just your regeneration. But the plasticity of the fiber tracts, the white matter, is still unclear. So the brain, the cortex, gray matter, just still compensate after injury of the white matters. Just the taken the carrying the cort the functional area to the different places, but the fiber tracts also we should take into account for surgical strategy before surgery to protect the especially neurocritical the white matter. So it's important. And the central core, the basal ganglia structure, is kind of like the autopilot. It's mostly related with the movements, the hyperkinetic or hypokinetic movements. We will discuss briefly later. So the outlines of my talk is going to be I will discuss the cortex first, and I want to show the neurocortical fiber tracts, and then the basal ganglia structures, and finally, I would like to show some case samples that the gliomas which use the fiber tracts for spreading out. So basic information for my younger friends. This is the central sulcus, and in front of the central sulcus is the frontal lobe and its executive functions. And the back of the brain is the occipital lobe. And what's the anterior border of the occipital lobe is the imaginary line drawn from the top of the parietal occipital sulcus to the perioccipital notch below here. The perioccipital notch is where the brain sits on the petrous apex. Between the occipital and the frontal lobe is the parietal lobe, which is the navigation center of the brain. And the inferior part, as we know, is the temporal lobe, which is the sound and the memory center of the brain. So the border between the temporal and the parietal is another imaginary line that drawing from the end of the sylvian fissure to the occipital line here. So the basic principle of the white matters, let's say someone called my name behind me, and first this sound, the information comes to the temporal lobe, which is sound center of the brain. And then this information is taken to the parietal lobe, which is a navigation center of the brain. Hence, I can understand the location of the sound and then turn back. Of course, the tumors know these borders. Answer is no. So the tumor, especially glioma, use the different the pathways for infiltration and to spread out. by up to date, we know the four the pathways. Of course, there are more, and we are going to discover in the future, hopefully. So the first thing is the glioma uses the brain parenchyma. We know there are some growth factor released, and this glioma just infiltrate the normal brain tissue, which is always problematic for the grossal resection for especially GBM. The second part is the leptomeningeal space. The tumor cells are lazy. They always looking for the last resistance area. So that's why that we see the glioma just infiltrates through the white matter instead of going to the cortex, because cortex has a lot of dense cells, a lot of resistance. So they want to try to escape like the less resistance place. That's the reason the leptomeningeal space is here. So what else we also know that is like the stem cell neuronal stem cells also using the coming from the subventricular zone and migrates like along to the leptomeningeal space to build the brain, the neocortex here. The same also same way we can see the glioma using the same way. The third one is the perivascular space. Of course, glioma needs the oxygen and want to close to the blood, the arteries, which is same thing with like the human always, civilized the close to the rivers, to the water, the same thing, because it needs the oxygen and glucose to get bigger. And this is also is considered as one of the major uh, uh, the problem for diffuse infiltrative growth of the tumors, the perivascular space. So the last one is the white matter tracts that I like to focus on today, which is the white matter tracts. And this is a when we see the tumors go travels the long range, like the distance, we usually go through or along the white matter tracts. There's a debate about it. So it's the sprayed the tumor sprays the white matter, splits the white matter, or gone along or through the white matters. But what we see the GBM cells, which using the white matters, their cell is usually more elongated because it's trying to fit this, the white matters inside the white matter. So we can say the GBM, especially GBM, travels through to white matter tracts. So what's the importance of this? Because if you know this white matter tracts anatomy, and we can just do our surgical strategies based on these extensions of the tumor, there's no doubt about it. Just the gross total supramarginal dissection still is the best, the gold standard for the extend the survival. So we're looking at the cortex right now, and for younger friends, and I usually try to find for the central sulcus always, like the challenging to find. I usually looking at the pre-central sulcus, the 100% opens the sylvian fissure. It's easy to find it. And then just behind it is going to be central sulcus. Central sulcus doesn't open the sylvian fissure. Only 5% of the sulci open the sylvian fissure. Once I find the pre-central sulcus, I can see the pars opercularis here, triangularis, and the pars orbitalis, which is a Broca's array, is another important, the center of the brain. What else we see here? If you follow the sylvian fissure all the way end to the end, very end, it takes us the supramarginal gyrus. And if I follow the superior temporal sulcus, it takes us the angular gyrus, which is the inferior parietal lobe. The parietal lobe is actually kind of junction of the fiber tracts, and the glioma of the parietal glioma has a really important and also identify the extension, because if you see laterally located, the glioma usually stay this part and pushing to the medial structures. More medial located gliomas in the parietal lobe usually cross to the midline, and we will see there are some tumors comes from the below, like parahippocampal gyrus, usually don't cross the midline, respect the midline, and goes up to the cingulate gyrus. So the MRI, basically I'm looking for the precentral sulcus here that opens the sylvian fissure. This is going to be just behind the precentral sulcus is going to be central sulcus. I can see pars opercularis, triangularis, and orbitalis here. The same thing here, pars opercularis, this is the central sulcus. For the deeper the slides, what I usually do, I looking for the central insular sulcus, which is the deepest sulcus in the insula. And this sulcus almost always runs the parallel to the central sulcus here. So if I follow this sulcus all the way up, I can find the central sulcus easily. It's important to understand the location of the tumor. Nowadays, I know already in Turkey also a lot of the center uses navigation stealth, but still important to know where is the location of the brain, especially for the eloquent area in eloquent areas. So let's look at the fiber tracts, and we have three types of fiber tracts, which is association fibers that connect this different region in the same hemisphere. We have commercial fibers interconnect the one side the other side. The tumor likes the fibers to cross the midline. We see in the front is the forceps from the corpus callosum. Forceps minor, forceps major is the back here. So the last type of the fiber tracts is the projection fibers that connect the cortex to the brainstem or the spinal cord. You see very large volume of the fiber tracts. We will see the glioma usually likes this. The fiber travels through the projection fibers, and we just like looking at the central. This is the central sulcus again. The precentral gyrus is the motor strip, and the behind is the postcentral gyrus, somatosensory the area. So if there's two centers of the brain for one function, usually the one in the front is usually motor one. It's like an engine of the car. The engine usually located in front, right? In the car, the same thing. So we will see the language centers, which is the Broca's area and the Wernicke's area. And the Broca is going to be the motor one because it's front. The same thing for the central sulcus, precentral and postcentral. So if you peel off the cortex, we encounter with the short association fibers that interconnect the neighbor gyri. At the deeper point, we see the long association fibers. Those fibers, like a highway, just interconnect the regions, the distant regions, from the frontal to parietal, for instance. DTI is a very important tool to demonstrate the fiber tracts, and in case of the presence of the tumor, also we can see dislocations of the fiber tracts that we want to preserve, especially what we see here, the arcuate fasciculus. We want to always preserve this arcuate fasciculus. So in the brain, there's a dual stream model for language and the vision. It means like, so language, there's a two ventral and dorsal stream. For the vision, also ventral and dorsal stream. For instance, this the occipital lobe again, which is the visual center of the brain. Let's say that someone just throw the ball towards me from far. The first, I just like the visual information goes to the occipital lobe, and then this information is taken to the parietal, which is navigation center of the brain, and I can just realize the location. Some object just come closer to me, and then I can also realize the location of the object. And at the same time, this information, the visual information, is taken to the temporal lobe, which is the memory and the sound center, and this is then I realize what type of object, like a ball. And this, the stream called what, and this stream called where. The same thing for the language. We have the Wernicke's area, which is sensory center. We have the Broca's area, which is the motor area. And we have dorsal stream for the language, which usually is related with the word production. Also, this is the arcuate fasciculus, And there's a ventral pathway, which is semantic, like meaning of the words. This is the inferior frontal occipital fasciculus usually the play the role for this the ventral semantic the stream. We know the Dr. Dufo also has a lot of the publication about this IFO, the inferior frontal occipital fasciculus. Just underneath is we see the uncinate fasciculus. The glia of the tumor usually like this the fiber tracts to spread from the temporal and the frontal lobe. Let's look at closer. This is the uncinate, which is the hook shape fiber tracts interconnect with the orbitofrontal, the base of the frontal lobe with the temporal tip and the temporal lobe and amygdala. And now we are looking from above, and here's the front, and here's the back. We can see the uncinate fasciculus has also subdivided two parts. The Leonard Hamer from the UVA, and he actually subdivided the uncinate fasciculus fibers, ventromedial and dorsomedial. So ventromedial fibers goes to the orbitofrontal, the area, but dorsomedial goes to the septal area and the gyrus rectus. So if you look at this, our paper with Dr. Muth, she's a staff in the University of Virginia right now. So if you look at this, the tumor, it's actually doesn't invade the gyrus rectus here. So this is usually the high likely use the ventromedial part of the uncinate fasciculus. But if you look at this tumor, just invade the septal region and gyrus rectus here, so that the tumor highly likely is spread out with the dorsomedial part of the uncinate fasciculus. So it's important because surgical strategy, the head rotation, everything is going to change based on the distribution and the extension. Another neurocritical structure is the optic radiation fibers that we want to stay away during the surgery. And we see the relationship of these optic radiation fibers with the lateral ventricle, which is atrium here. If you look at this, the atrium is like the pyramid here, and the upper 1/3 is free from the optic radiation fibers. And when we use the intraparietal sulcus to get to the cortex, and it's usually, the free from the optic radiation fibers. So those are tapetal fibers, which is a part of the corpus callosum. When we think about the general textbook information, the corpus callosal fibers usually goes up, but we know that is some fibers from the splenium especially goes down to make the lateral ventricle wall, and is separated from the optic radiation fibers with the ependymol of the ventricle. So looking from above right now, this is the atrium again. We see the optic radiation fibers. So if the tumor is originated from the lateral to the optic radiation fibers, usually push all the structures medially. But if the tumor, this is the tapetal fibers again, a part of the splenium. The tumor is located here. Usually goes and it has a tendency to to cross the midline to go to the other side. But if the tumor is located here, we usually less likely to see the crossing the midline. So this is insula meaning is island, and insula is another important structure. This can be called the central core or the insular lobe, or the basal ganglia structure is going to be located medial to the insular cortex. The insula is encircled with the limiting sulci, which is inferior limiting sulcus, superior and anterior limiting sulci, and there's a junction of the superior and anterior is the anteroinsular point. The Dr. Tre described this, the points, which is important, especially for like the Kawas malformations or something, to see the relationship of this of the tumor related the relationship of the tumor with the surgical landmarks. And the junction of the superior and the inferior limiting sulci is called inferior, is the posterior insular point. Also, gyrus, Heschel gyrus also just attached to that part here. So another controversial, the issue is the most anterior part of the optic radiation fibers, which is also called the Mayer's lobe. Why is important? Because we see that this is an inferior limiting sulcus, The temporal stem, description of the temporal stem, there's two options. First, some authors, only 1/3 of the inferior limiting sulcus is called the temporal stem. The some authors just, like the describe the temporal stem as all inferior limiting sulcus all the way here. So when I asked Dr. Walton, he he preferred the second way. Just we can call this all inferior limiting sulcus as a temporal stem. It's important for the epilepsy surgeries or reaching out to the medial temporal lesions here. So the only one thing is this is the limit insula that can be recognizable during the surgery once we open the sylvian fissure. And this distance from the most anterior part of the Mears loop to the limit insula usually around 6 millimeters, which means if you go more backward, you're going to cut the articulation fibers here, especially Mears loop. What happens? So if you do cut the Mears loop, it's going to be upper quadrant tonopsia on the contralateral side. In some country, the traffic lights on the right upper, and in Europe, and I think is in Turkey too. And so then these people like having a hard time to get the driver license because they don't see on the right upper side if you get the surgeon the left, the cut the left side of the Mears loop. This is a stance. This is the pin that stands for the lateral geniculate body, and we see the articulation fibers and its relationship with the temporal stem, or in other words, with the inferior limiting sulcus here. So, what's the basal ganglia central core structures? This structure is located between the insular cortex laterally and the lateral ventricle medially, and we have like claustrum, external capsule, external capsule. Those are white matter, just kind of only anatomical barrier here. And we see the putamen and the globus pallidus, also called lentiform nucleus, together. We see the caudate nucleus. We see the thalamus it's not a part of the member of the basal ganglia structures. There's a thalamus is diencephalon, is a different thing. But what we see between the structures, we see the internal capsule is very important. So there's an anterior limb and posterior limb, and the junction of these limbs is the geno. Geno has a lot of motor strip, the fibers that we want to stay away, and just medial to the geno is foramen murru. We see, and this is another specimen. We see the insular cortex laterally and the lateral ventricle medially, and between these structures is going to be like this is the external capsule, which is formed by the inferior frontal occipital fasciculus, and you see the putamen here. Of course, it's difficult to reach out because we see a lot of MCA structures, everything for insular area. So another important the fiber tract that the tumor, the glioma likes the travel anterior commissure. Now we are looking from below right now, and this is the front. We can see the olfactory nerve here. This is the bag, and we see the anterior commissure here, just interconnect one side to the other. We see some glioma just using the anterior commissure and then cross the midline through this fiber tracts, and it's interconnect with the temporal and occipital area with the one side, the other side, also amygdala here. So this is the lateral view, and still the relationship of the structures. We see the anterior commissure. This is the anterior crus, but this is the anterior commissure here. Just behind the anterior commissure is going to be geno of the internal capsule, and medially we see the foramen murru here. And at the very lateral and the cortex, it corresponds to the posterior short insular gyrus. This is again, here's a central insular sulcus, which is the deepest sulcus in the insula. And in front is the short gyri, and the behind is the long gyri. And this is the posterior short insular gyrus, which the same coronal level as the geno of the internal capsule, which is just behind the anterior commissure and then foramen murru. Of course, during the surgery, it's difficult to recognize all these structures, but it's important to identify on the MRI to find, the exact location of the tumors. So what else we see here? The caudate nucleus is very important. The automatic the movements it's involved in. We see the caudate nucleus that has head body and the tail. We know the glioma can arise from the head of the carotid nucleus, but usually don't uh, travels through the body or the tail. Don't mess with the body and the tail. Just stay there and just like start growing and pushing the surrounding structures. So if you look at this those are the sulci, which means also the border of the insula, and the head of the carotid nucleus is located inside the insular border, which means if I go, this is the anterior insular point again. If I go the follow the anterior insular point, so I know where's the carotid nucleus. The body of the carotid nucleus is located above the superior limiting sulcus, and the tail here. So this tail also crosses the temporal stem. If we open the mesial temporal area by cutting to the temporal stem here, we also cut the tail of the carotid nucleus. What we see usually, we see the temporary difficulty of the initiation of the movements here. It's usually temporary, but it's kind of we don't know exactly what's the reason, but we just think is related with the cutting the tail of the carotid nucleus. Because the carotid nucleus has a lot of loops, it's related with the hyperkinetic or hypokinetic movements, like a Parkinson disease, Huntington disease, or we can see some, like the ADHD or some OCP, obsessive compulsive disorders, OCD, the problems when we see any the problem with these loops, which called cortical striato thalamocortical loops. The carotid nucleus play the major role of these loops. And this is a paper together with Dr. Musa Chrak. And finally, let's see the limbic structure, the system. This is the amygdala, and we see the hippocampus here, and hippocampus, the dentate gyrus, and this is the fornix. You see the fornix. The information comes from the parahippocampal gyrus and the hippocampus, and travels through the fornix and goes back to mammillary body, and then from the mammillary body go to the thalamus, and from the thalamus go to the internal capsule, and finally comes to the cingulum or cingulate gyrus and come back. This is called a puppet circuit. So this is the Yash-Egel classification for the limbic paralimbic tumors, different parts. You see that each part is different, and what we see usually, if the tumor arising from the hippocampus, usually in weight to parahippocampus too, but what we usually see, if the lesion, the tumor glioma arises from the fornix, usually stay inside the ventricle. And this is here is the fornix. Fornix also forms the roof of the third ventricle. If the lesion is the tumor is located from the parahippocampus, or sometimes a part of hippocampus, just goes to up and behind the splenium of the corpus callosum and goes up to the corpus callosum this way. So, and the splenium also, this is a part of corpus callosum. We can see the tumor can extend superiorly through the pericuneus, or sometimes using the forceps major and goes down. This is one of the sample of the case, and we see this is splenial tumor. It's crossed to the midline, and you see here it goes to the pericuneus area, and this tumor using the forceps major fibers here goes up the pericuneus. And this lesion is it's originated from the hippocampus, and it travels back, and just the extension of the dentate gyrus is the inducium gracium here. So two options: either stay this way, goes inside the ventricle by fornix, or if there's a lesion located from the parahippocampus, just travels backward, goes up. Sometimes, of course, they stay here and then get engulfed this temporal lobe here. But if you look at this one here, so it's just it goes backward up, and you see like it actually respect the midline here, so it doesn't cross big tumor, but still doesn't cross the midline because it comes from this way and stay the same the hemisphere and goes up instead of crossing the midline. So what we see here, this is also, you see this is that tumor is actually medial, just start from the medial, the forceps major and the parietal lobe, and just, the cross the midline goes the other side. This is another sample. It's just they start from the hippocampus or hippocampus here, but it's just, like the growing backward and up top to the corpus callosum instead of is pushing the splenium here. You see, instead of the crossing the midline. So the perivascular space, leptomeningeal arteries, and we know the neuronal stem cells using the pathways to build the neocortex, and the tumor also using the same pathways. You see here, like this is the GBM, just like the wedge-shaped GBM, and come to the lateral ventricle of the wall of the lateral ventricle here. So there's the two options when you see that kind of tumor. When you resect this one here, the C ependema, some, the authors, the surgeons want to open the ependema. Some surgeons want to stay, doesn't touch the ependema. And 2 years ago, Michberger just published a paper about long-term results for versus opening the ependema, not opening the ependema versus he didn't find any difference the surgical outcomes and survival between the opening and not opening the ependema. So the stem cells likes the niche, which is called a niche, kind of like microenvironment, because it needs, like the oxygen, like the different kind of the glucose, the sugar, everything to get, to grow. The tumor cells are the same thing, so similar things, and this using the same niche in the tumor cells and the leptomeningeal area, the leptomeningeal arteries, the perivascular space using this way. This is another example. You see this tumor originates from the parahippocampus. It's pushing to the structures, the hippocampus, pushing the hippocampus here. So it's growth to the temporal lobe. Like, let's say it's arise from the parahippocampus here, this one. But when we see the tumor arise from the laterally, neocortex of the temporal lobe, usually just, like the following to the uncinate fasciculus go to the frontal lobe here. But if you see the tumor arise from the parahippocampus, usually, the preferred is stay here and then pushing, growing here, and then pushing the structures laterally immediately. Of course, the Schramm classification, the Schramm from the Germany, he has a different classification for the temporal basal structure tumors, and it shows that there's a type A, B, C, D, and the tumors arise from here, goes to the insula up here. So it's possible. The thing is, like once the grade increased, the tumor is getting crazy, and then just there's no any rules anymore. So we can do everything, just destroy the fiber tracts, destroy the gray matter, and get a necrosis, like also, like some hemorrhage or something. So I want to show this one other things here. So this is here is the lentiform nucleus again, which is the combination of the Temen and Gliomas pallidus, and this is called the lentiform pedicle. It goes up. Actually, it's actually related with the amygdala. It's touched the amygdala. The gray matter of the amygdalas just, extend up to the lentiform nucleus here. This is called the lentiform pedicle. It's not very well known, the structures, but you can see during the if anatomic dissections here. So this is another path. Sometimes, the mesial temporal medial basal tumors goes up to the insular area with through this, the gray matters too. This is another path. I think it's that's all what I would like to share with you guys. Please let me know if you have any question or contribution, and thanks for your attention.
Thank you very much for this detailed and informative lecture.
My pleasure. Thanks for having me here again.
Thank you. Before moving on our guest question and comments, I would like to ask a question. Are the white matter tracts in the cerebellum similar to those in the cerebrum?
The fiber tracts is kind of like similar, but is the architecture is different because the cerebellar fiber tracts comes from the pons and the spinal cord, which is more stiff compared with the fiber tracts in the cerebrum. Um, Also, the architecture of the cerebellum is different, so it's get more cortex is very thin, and the cerebellum um, cerebellum is enriched with the white matters, I would say. Um, the cerebellum also has own subcortical gray matter, which is also called basal ganglia structures of the cerebellum, which is the dentate nucleus, emboliform nucleus. That is a similar, like the structures, architecture, but it's I would say just a little more stiff than the white matter fiber tracts in the brain.
Thank you. Thank you very much. Uh, as far as I can see, there are no questions in the chat yet. Okay. Dr. Ahmet Özak, right chat. Thank you, Kaan Yağmurlu. It was an outstanding presentation, like always. Dr. Ahmet from Akdeniz University. Thank you. Dr. Orhan Mamakatli, right chat. Thank you very much for wonderful lecturer. Okay. As far as I can see, there are Efecan Erişken, Dr. İzmir Atatürk Training and Research Hospital. Thank you for great lecturer. Do you use trajectography in every case which located in eloquent area?
Here we don't usually use the DTI, honestly. If we have intraoperative MRI and also functional MRI, sometimes the functional MRI also takes time and very subjective based on radiologist. But for eloquent area, we prefer to do like awake craniotomy, and it's or just like to try to be very conservative about those. But the DTI is important, of course, for electron areas. It's kind of like I work with like 7 Tesla MRI for the DTI, 3 Tesla MRI for DTI. It's still, like the not total objective, it's subjective things. Of course, it helps. Even like the 1%, if it helps 1%, it's big thing. But still, like the accuracy is not like pretty good, I would say. But of course, can be used. Why not?
Thank you for your answer. Recep Şavik, Dr. Recep Şavik, thanks, right that. Dr. Ümit Kepoğlu, dear Kaan, thank you for a great lecturer.
Thank you.
Okay. Dr. Musa Çırak, thank you for your great lecturer, my mentor.
No, it's not. We just work together for like 1 month, 2 months. A very close friend of mine, Dr. Truck is. I'm not. I mean, I can't be your mentor. So just have a lot of experience, Dr. Truck.
Okay. As far as I can see, there are no questions in the chat yet. So I want to hear from Professor Bektaş Açıkgöz.
I would like to thank Dr. Kaan for his excellent lecture. Thank you very much. Congratulations.
Thank you.
I hope good luck in your studies in United States. Hoping to see you someday in Turkey. Thank you very much.
Thank you. Appreciate that.
Thank you.
Thank you very much. Dr. Osman Tanrıverdi, Thank you for your good presentation.
Thank you.
Also, I want to hear from Professor Bayram Çırak.
Musa Çırak, you mean?
Musa Çırak.
Like to say something, especially for young neurosurgeons. In 2019, I had opportunity to study together with Dr. Yağmurlu, and he was very great neuroanatomy experience, and he contribute my neurosurgery. He contribute my neurosurgical life, and especially I recommendation to young neurosurgeons, if you want to learn neuroanatomy, the Khan is the best of this job, and especially he's very good mentor. I really talks with my heart, and I recommend all the young neurosurgeons to learning the neuroanatomy. If they want to learn neuroanatomy, and they can choose the Dr. Yağmurlu. Thank you, Dr. Yağmurlu. With my all best, with my heart, I will tell all this. And my English is not enough to explain my emotions.
It's very kind of you. Thank you so much. So,
Thank you very much. Dr. Emmanuel Moulat, very instructive, great experience. Thanks.
Emmanuel is the medical student in our university, is third grade. Not doctor, he is watching us. Also, Davut, next question is from Ali Sanışık. Ali Sanışık is my friend from high school from 40 years ago, or
Okay.
45 years ago. And maybe he want to ask himself. Ali San.
Thank you very much, Dr. Sucu, and I would like to thank Dr. Kaan Yağmurlu for his excellent lecture. I have a question that, as I write, do you have any experience neurofiber anatomical pathway change their route during the glial tumor invasion in degenerative brain parenchymal diseases like Alzheimer? Do you have any special experience to share about us?
thanks for that's a great question. I also Ali Sanabi is attending my staff when during my residency work here. I learned a lot from him. So that's a great question. So we know that Alzheimer disease causes the sunking of the fiber tracts. We see like the brain, autopsy brain, where the people with Alzheimer just brain getting smaller and the fiber tracts still there connection, but the volume just the size smaller than the healthy brain. But I don't have any idea about like the trajectories, like the extension. I don't think, because it destroyed, but only size. It's not like the route or trajectory of the fiber tracts are being destroyed by the Alzheimer or any other neurodegenerative disease.
Thank you very much.
Great to see you.
Thank you very much for answer. As far as I can see, all questions and comments in the chat section are over. Now I would like to give the floor to my teacher, Professor Dr. Hasan Kamil Sucu.
I want to thank again to Dr. Kaan Yağmurlu. We saw today. Fantastic anatomic dissections like Vermeer's paintings, almost. It was great to watch, to see. Thanks again. I want to thank everyone who joined us. It was a good evening for us, or good afternoon or noon for Kaan Yağmurlu. I want to thank everyone. I hope to see you in Turkey or in United States in real life.
Inshallah.
Thank you so much.
Thank you so much. Thanks for having me here. Again, always feel at home because seeing, like the people from Turkey and just, thank you so much.
Thank you very much.
Okay. Bye. Ertan Sevin wrote to me from privately, but I think he didn't write to chat part. Okay. So I will close the meeting for now.